Uh, Welcome everybody to the Global Public Health Week. I'm Michael Moore. I'm a past president of the World Federation of Public Health Associations, and today I have the pleasure of interviewing Andrea Parisi, Dr. Andrea Parisi, about a range of things in her career at this stage and how she implements public health policy on the ground in particular. So, Andrea, welcome.
Thank you,
And
Michael.
I note that you have a medical degree from a Czech university. Is it University of Prague?
It's a Charles University in Prague, yes.
Aha. And a PhD in epidemiology from the Australian National University, but you're also studying in Spain. So why have you pursued such a diverse career so far? Perhaps you could enlighten us some of your background as part of that response.
Yes, of course. Thank you for that question, Michael. Look, it probably just it was just life as it happened. I had it very clear on very early on in my career that if I want to pursue career in public health and or research, staying in Czech Republic would make that career quite difficult because unfortunately public health as a discipline is not given much of a focus, especially in the recent years with government cuts. Unfortunately, for some reason, governments don't see prevention as a major focus. And there is less and less funding going into public health institutions. And research also is unfortunately not a very strong area. People working in research in the Czech Republic are usually, I would say they almost do it as volunteers in their free time. They are very often not paid, or they are paid very little, and they do it in addition to their regular job. So, and again, overall, there is not much funding. So it's as a researcher, if you want to make a career, it's probably not the best place to stay, unfortunately. And same with public health. So when I was actually before my medical degree, I had the pleasure of staying 1 year in Australia, and absolutely fell in love with the country. And of course, I was young, and I didn't see also the other side. Not everything is positive, but I did fall in love with the country, and I decided that I would like to come back one day and pursue a career in research, which I did. I applied for Endeavour postgraduate scholarship after medical school, and I was very lucky to get it. And I started studying at the Australian National University, investigating invasive and multi-drug resistant salmonella infections. Salmonella is also very close to me. It's a very, very common pathogen in the Czech Republic.
You need to say that a little bit more slowly, Andrea, because I think we missed exactly what you were researching.
Oh, yes, apologies for that. I was researching invasive and multi-drug resistant salmonella infections.
Yes.
They are very common in Czech Republic and as well as in Australia. So it was a really interesting topic, but it was not that much about salmonella. It was more about equipping me with research skills, how to design research, how to implement research findings. So that's how I ended up in Australia, and now I'm actually in Spain. During COVID, well, also after my PhD career, I felt that I would like to move from academia more into applied field epidemiology, and there are various field epidemiology programs around the world. In Australia, there is one called MAE, Master of Applied Epidemiology. You have Epidemiology Intelligence Service organized by Centers for Disease Control and Prevention in the United States. And in Europe, we have very similar to your program, which is organized by the European Centers for Disease Control and Prevention, called EPIET. And that's the program I'm currently enrolled in. I was lucky enough to be placed in Spain. I did study for 1 year in Spain during my medical studies on an exchange program. So I speak fluent Spanish, and also I understand a bit country. So when I was placed there, it really helped me to build on that previous knowledge. And I'm just about to finish the program. So that's quite, as you said, it's a quite diverse career, but it was never, I've never really planned it step by step. Just that's how life happened, and I took the opportunity I was given at any given moment.
Well, I think that's the case for many of us, I have to say. So, but I also understand that you have done some work in the Pacific and other developing nations. So before we go to talk about Africa, which is the main thing we'll be discussing today, can you just give us the background of other work you've done in terms of public health, epidemiology, and so on?
Yes, you're absolutely right there. I did spend couple months in I did a couple of research internships. My first internship in Asia Pacific was in Thailand at Chulalongkorn University in Bangkok, where I worked at the Department of Neurophysiology. Later on, I worked as part of my PhD at the Oxford University Clinical Research Unit in Ho Chi Minh City, investigating sources of antimicrobial resistant infections in humans. And later on, when COVID-19 pandemic hit, I was deployed with the Australian medical assistance team to Papua New Guinea as a public health doctor to evaluate the situation and provide recommendations to both the Australian and Papua New Guinean government. Later on, this role led to the offer of a health security lead as part of the Australian Papua New Guinean Partnership Program, which was focused not only on COVID-19 response, but also on other projects, other existing projects in public health, particularly on tuberculosis, multi-drug resistant tuberculosis, and malaria program in Papua New Guinea. So this was the experience in Asia Pacific. Unfortunately, my role in Papua New Guinea as a health security didn't last very long because of the personal issues. I had to return back to Czech Republic. I ended up working in a Czech hospital as a clinician at the COVID ward, infectious disease wards, and others where needed. And then I involved in the field epi training program that I'm currently at.
It's interesting how COVID disrupted so many things in life, and for all its downsides, there are also many things that we learned
Yes.
from that. But more recently, you have been working in Africa, first with Medecins Sans Frontières, and then later with the World Health Organization. Would you like to let me know how that came about and the sort of work you've been doing first with Medecins Sans Frontières?
Of course. So I was deployed with MSF to Zimbabwe to assist with cholera outbreak. The time that I was deployed was just before the peak of the outbreak, and I ended up being the only epidemiologist that MSF had in country. So it was an extremely challenging and exhausting work. I was pretty much responsible for all sectors of epidemiology, so data collection, data analysis, reporting, writing of concept notes. I was visiting cholera treatment centers, trying to understand how they collect and report data. Unfortunately, at that point, MSF did not have access to the national line list, the national data, which made the decisions to either enter a certain area or exit very difficult. So before I came in, I was replacing an epidemiologist who went on leave.
Yeah.
But the time I came in, there were no analysis for several weeks. So MSF was kind of blind in a way where to go. So obviously coming in and trying to collect data gave us a bit better understanding of the situation. And we started moving in country from areas where the cases were going down to more alarming hotspots. And I had a great pleasure working with another specialist on water and sanitation and hygiene in cholera. That's another pillar that we epidemiologists work with, is that's the main source of transmission. So we were kind of trying to figure out what are the most contaminated water sources, distributing WaterGuard, which is pretty much chlorine, so that people could chlorinate their own water. And advocating for the oral vaccine, which came in towards the end of my deployment. And we could have seen the cases started going down about a month after the implementation of that. Unfortunately, the coverage was not for the whole country due to the global lack of cholera vaccines, but we believe that it significantly contributed to the decrease in number of cases. Also, we were coming to an end of rainy season, which has also impacted on the decrease. So
you touch on something that's really interesting to me, and that is whenever we seem to be dealing with these situations, there's hardly ever a single solution. People go to, we just need to vaccinate, we just need to do it. And I note the same with malaria, we just need to vaccinate. No, what about treating the mosquitoes? There's a whole range of things, bed nets and so on. So can you just elaborate on the series of things that needed to be done that you saw as a physician and as an epidemiologist?
So in cholera response, we typically work in different pillars. Of course, for me, the main responsibility I was given early on was in the pillar of surveillance. So trying to understand the data to be able to apply measures in areas that were needed and to see trends. And of course, when I came in, MSF had no trends on case fatality rate, on weekly incidence rates. We did not know which regions we should focus on. So this is the first work we started working on, developing some sort of a data platform, collecting data from cholera registers and communicating with the Ministry of Health, receiving data from them and trying to analyze it in our data platform on a regular basis, which worked, and we started moving from areas which were no longer considered as needed to those that were, because we have to realize that MSF does not stay in an area until there are 0 cases of cholera. MSF works as in an emergency context. So once we don't consider a certain number an emergency, and we develop certain indicators that told us when it's not going to be considered an emergency, we moved from that area to another one. So this could be something like doubling in case fatality rate, or WHO recommends case fatality ratio to be under 1% for cholera. So we were looking at, for example, doubling in incidence rates over 2 weeks period as a place that we should intervene to. So this is the surveillance sector. Of course, I've already mentioned water and sanitation hygiene. To me, very important in cholera. We started testing some of the wells in the capital city and surrounding regions where we worked, trying to understand the concentration of chlorine and residual chlorine, and distributing of soap and water guard as a chlorine to the households. There was some sort of a contact tracing going on. We would not typically do contact tracing during cholera, especially if we have so many cases, but that type of, although it was called contact tracing, it was more also as some sort of risk communication. When the teams were going into the households, they were asking if someone is not sick. So I would say more of an active surveillance, active case finding.
Coming back to Jon Snow, isn't it?
Yes, yes, that's exactly my thoughts.
Yeah.
And unfortunately, we could not apply the same measure as he did in London, because unfortunately, almost every household had their own borehole or their own well that they built, and it was very often very superficial and contaminated.
Yeah.
So we very soon realized that the infrastructure is very poor, and the investment in infrastructure, there have been some estimates in country be billions of dollars, which is not it's not possible during the outbreak. So we considered as the main measure chlorination and making sure that people have access to safe drinking water by chlorinating it. And it's very easy. You put 1 cup of chlorine into your 20-liter bucket water, you wait half an hour, and then it's safe to drink. And then, of course, so this was in water and sanitation hygiene. Then, of course, building of cholera treatment center and cholera treatment units, so that people are treated separately from other patients in the hospital. and the care is specialized. And clinicians, mostly nurses who were working in these centers, were provided proper training, and they were given enough antibiotics. So making sure that they have enough PPEs as well, personal protective equipment. And they were trained enough on different types of dehydration, making sure that they put the patient on a proper treatment plan. Then, of course, setting up our rehydration points in the community as sort of a first entry point for people with symptoms, from where they were typically referred to cholera treatment centers if their symptoms were more moderate or severe. So this is in infection control prevention and clinical care pillar. And then, of course, we have laboratory pillar. So
Yes.
making sure that we are doing testing, although the case definition of cholera and that's something that I try to explain in many areas, as well as later during my work for the World Health Organization. Once there is a declared cholera outbreak that has been microbiologically confirmed, you no longer need to test for cholera. You only rely on clinical definition. So people with people with acute watery diarrhea, with or without vomiting. That's
Yes.
it. That's your definition. So you no longer have to test, but the country still chose to do rapid diagnostic tests and culture to see what's the antimicrobial susceptibility of the bacteria and to monitor the trends. So supporting the MSF, we were no longer supporting the pillar of a laboratory. We were no longer provided rapid diagnostic tests because it was deemed not longer necessary, but the government was still doing that on not on every isolate, but they still were doing that. And of course, we have another pillar of risk communication. So, when I arrived to the country, there was no really information on cholera because the government has not officially declared it. It's always a very political issues. I'd rather not talk about the reasons behind why the decision was made in such a way. But of course, if there is not a legally declared outbreak, the response is much more difficult. And also, overall understanding is not as clear. So one of the things we did, we organized a risk communication campaign that was distributed through social media mostly, because that's the main channel in Zimbabwe, and through radio on what are the safe procedures for cooking, what's cholera, how it's spread, what are the symptoms, what to do in case of certain symptoms. So it's always important to keep in mind that you can't, in cholera and many other outbreaks, infectious disease outbreaks, you cannot just focus on one pillar of response. It's a multi-pillar, multidisciplinary approach. And of course, to me, water and sanitation and hygiene, that's probably the one that should be mostly focused on
Number one.
Response.
Since that time, you have, after completing that work, you then were asked to do some work with the World Health Organization. Tell us a little bit about that work and the challenges that you faced and how those challenges compared to working with MSF.
So very different role again, not only because of the type of organization that WHO is compared to MSF, which is mostly clinical organization, but also due to the timing. So when I was deployed with MSF, the mobilization happened very quickly because MSF works as an emergency organization.
Yeah.
They deploy people in a very short period of time. They work during the emergency and then they withdraw and deploy people somewhere else needed. World Organization is an organization that I would say is more of a long-term sort of strategic advisory and planning in country, which is very closely working with the Ministry of Health. It has also a very different type of funding. So with MSF, as I've mentioned already, I was deployed just before the peak of an outbreak when the cases were rising up every day, and pretty much 1 week after my arrival reached its peak. with the World Health Organization, I was deployed to Zambia, also helped with cholera outbreak response. However, we were at the end of the outbreak. So there was a shift more towards, rather than managing the outbreak, focus on training and capacity building so that the future cholera outbreaks, so that the health personnel is better trained and can better respond to future outbreaks. Also, my mobilization took quite long. I remember first applying for mission sometime in January, and I was deployed at the end of February. So actually, when there was a call for an epidemiologist, it was when the cases were peaking. But by the time I was deployed and my other colleagues who were deployed with me, it was coming to an end. But it was still a very, I think, very interesting and valuable mission, because I got this question very often asked when I was doing training in Zambia, when healthcare workers were asking me, why are you giving us training now when we are at the end of an outbreak? And I would always ask them, do you think this is the last cholera outbreak you're getting? Unfortunately, if the main threat, which is the infrastructure, is not fixed, then we have to expect more cholera outbreaks. And this was not the first, and I don't think it will be the last. When I came to Zambia, it was supposed to be rainy season, but it did not rain once. The government actually declared the drought as a national emergency. And people very often think that once you have a drought, there is no cholera. But drought as well as flooding are risk factors for cholera, because you either have too much of contaminated water or you have no water at all, which then makes you more prone to take any water that's left and that might be contaminated. Of course, associated issues with drought, malnutrition. It's a society, we have to realize that that's really dependent on farming. So many families, they live on their own farming, and harvest, of course, this year is not going to be the best because lack of water. So very different situation. Also, I've noticed there is a very different relationship between the government and MSF, Medecins Sans Frontières, as an NGO and a World Health Organization. My colleagues would very often say that the WHO works more of as a secretariat of the Ministry of Health in a given country. That's kind of as an advisory organization next to them, provides ongoing support for strategic planning, can provide technical support as well. And very often has access to the national data. Of course, which makes
Yes.
Exactly, which makes the work of an epidemiologist much easier. And therefore, I was not expected to do any data analysis as I was doing for MSF, because there was data and we had a whole team that set up automatic reporting and data analysis in statistical programs. So there was no need for me to do that. And I had daily briefs that were coming both from the ministry and from our own team, which were guiding us pretty much on the development of an outbreak. This is something we did not have with MSF because, as I've already mentioned, it's a very political, every outbreak is very political. And there's always fear that the data will be shared beyond the organization, and then somehow the country will be looked at badly. So there's always this fear, which then makes the collaboration a bit more difficult. So in terms of epidemiology and kind of understanding the situation in Zambia with WHO, it was much easier for me. So I was able to concentrate on other pillars. And I actually started working in a surveillance pillar at the beginning, but then it turns out that there's really not such a need for me to do that. So I transitioned to infection prevention, control, and water and sanitation hygiene. And pretty much during the month of my deployment, I was going to different cholera treatment centers across country, and I was doing an assessment and training on-site mentorship. So making sure that cholera treatment centers had proper waste management, that their staff use adequate personal protective equipment, that they had a good understanding of different treatment plans, and when we do and when we don't use antibiotics. Making sure that the cholera treatment center is set up properly, that there is a proper donning and doffing station, that there is a triage before, and the patients are not mixing in different zones, that there are toilets separate from staff and from patients. So really, that there are standard operating procedures for disinfection, that the staff is vaccinated, etc., etc. So it was more of a preparation kind of assessment, overall assessment of preparedness, and providing training to environmental health officers, public health nurses, and clinicians. We also did a couple of trainings across country in different provinces, both to the Ministry of Health and clinicians working in cholera treatment centers and our rehydration points. And I think it was very well received. Ministry of Health seemed to be very grateful to our work we were doing. They really considered us as professionals in the field, and they were really, really collaborative and happy to take our advice on board, which was making the work much easier. So it was a good mission, but I felt when I was leaving the country that it was a successful mission.
It's interesting listening to what you say. You just said, almost as an aside, that the politics behind it is always an issue. And in all my teaching and as president of the World Federation of Public Health Associations, when I was CEO of the Public Health Association of Australia, I often used just a single sentence in my teaching: public health is political. And I think sometimes people forget that very, very important aspect there that fits in with all this work, and the understanding you've now provided to the sort of thing that goes on, the sort of work, has been really, really interesting to me, and I'm sure to those who listen to this in Global Public Health Week. I think, Andrew, I've got a final sort of broad question for you, and I did give you warning that I was going to ask it. If you were president of the world, what would you suggest are the 3 most important actions that you would like to see to improve health internationally, and particularly in the global south?
It's a pity I have only 3, but look, when I look at the global burden of diseases, we have seen a shift from communicable diseases, which still remain quite prevalent in low-income countries, to chronic conditions such as cancer and cardiovascular disease. Unfortunately, even these we are starting to see on rise in low and middle-income countries, due to change of diet and kind of westernization, let's say. So I guess the main public health measures I would take would be focused on these issues. And of course, as a public health professional, I could not stress the importance of immunization and vaccination. I think my colleague would be very unhappy if I did not mention these. Unfortunately, it seems COVID might have taken a toll on the perception of vaccines. But what we tend to forget is that there are so many diseases that we no longer see thanks to vaccines. And interestingly enough, if you come to any mother in Africa and you offer them vaccines, they will take it without hesitation. So there is still this perception of the vaccines and the importance of vaccinate the children. And I'm talking now about vaccinations in primary immunization series that should be given to every child. Measles, mumps, rubella, tetanus, diphtheria, all of these, which, I am quite concerned about looking at some parents who are no longer willing to vaccinate their children for whatever reasons. We still look at these anti-vaxxers websites that are citing the Wakefield study that had fabricated data associating measles, mumps, rubella vaccine with autism. And we still, although this has been retracted from Lancet many years ago, we still see this as a sort of a core study that's cited on many of these anti-vaccine websites and cited by many parents. So I think I would advocate for immunizations in children and the importance of vaccines and developing policy around it. Because if one's child does not get vaccinated, we are not only putting the risk at risk that child, we are also putting at risk other children that that child is in contact with. And I don't think it's fair. I always think that we have, as humans, we have our rights to protect ourselves, but our right ends there where a right of another person starts. So I think we have to be very conscious of that, respecting boundaries, but also be aware of the impact our decisions take on others. So this is when we talk about vaccinations that are already have been established for many years, and we have seen in Czech Republic, and I think even in Australia, we have seen now rise pertussis. We see measles outbreaks, something that I think we should not be seeing by now, because there is an effective vaccine. We are not
Really
talking about
effective. Yeah.
we are not talking about malaria vaccination that has 39% efficacy. We are talking about vaccine that really works.
Yeah.
So advocating for that. And now that I've touched on a topic of malaria, we have seen that the global warming, the climate change has taken an impact on the spread of infectious diseases. And I always say that climate change impacts every sector, and people always think it's just ecology and environmental problem, but it's not. It's a public health issue. And we see the diseases that used to be prevalent and endemic only in certain areas of the world now spreading to industrialized countries. We see dengue and other arboviruses on rise in Europe. And I think it's just a question of time when we see malaria and other vector-borne diseases in Europe as well. And we are not prepared for it. So I would also, as part of the vaccination strategy, I would also advocate for development of new vaccines on malaria and other vector-borne diseases that have higher efficacy. And as part of that is distribution to lobby to pharmaceutical companies to either offer these for free to less developed regions or at much lower fee, so we can ensure a higher immunity. So this is kind of an immunization policy sector.
Yes.
Now, if I go to the other two, again, they are related to the global burden of diseases. And now I will transition to more of a chronic conditions, cardiovascular disease and cancer. I come from a country where beer is cheaper than water. And although many Czech people would be very unhappy for me saying that, I don't think it's right. I don't think it's right that if you are as a kid and you go with your friends somewhere, you prefer to get a beer because it's cheaper than water. We even have beer spas, which are very famous among tourists and among my friends in Australia. Again, that's just a part of the problem. I think we have to ensure that the community is provided healthy food, non-processed food, the food that does not have endocrine disruptors. We see a lot of issues with thyroid and others that might be associated to these endocrine disruptors that are now used in our diet. And I've noticed in Australia, similarly as in Czech Republic, some sugar drinks are cheaper than water. Processed food from fast food restaurants is cheaper than a salad, than fruit and vegetables. I think we as organizations, a public health organization, we have to lobby to governments to ensure that healthy food is provided to the population, that people can access it easily, and that it's cheaper than the processed food. Because if you have big family or family of four, it's of course much cheaper for you to go to a fast food chain restaurant than to get a salad, which is to me really wrong, because if you look at other countries in Asia and Africa, the processed food, the fast food is the most expensive, because that's the one that needs some work. Whereas the fruit and vegetable you can grow in your garden, that's the cheapest thing there. And that's, I think, that we kind of forgetting, and that's how it still should be. We should be able to access healthy food, and that should be much cheaper than the processed one. So advocating for that.
And the third thing?
And the third thing, I'm going to give an example of New Zealand and its policy on banning smoking. To me, this is a very, it's a very thing. And it seems to be a much easier thing than, ensuring vaccinations for all. It's a simple change in the law. Cigarette smoking, as well as vaping. I don't want to forget about vaping and e-cigarettes. To me, it's a drug, and it should be treated as a drug in the legal system. And that New Zealand was the first country that officially approved ban for smoking. It was approved, I believe, in 2023 and will be officially applied from 2025 onwards. We know that smoking...
Except they've had a change of government.
Oh, that's correct.
While you've been away, they've had a change of government, and they are basically, you said it's political. All public health is political, and the system they were using was people of a certain age are no longer able to purchase cigarettes, and it just goes through and follows them through. And that system is now been undone by the Conservative government being elected. However, it's an example that the law passed and should be considered.
Yes, so hopefully let's hope that this will go through, because we know that lung cancer is directly associated with smoking. So eliminating that risk factor, we could decrease the burden of cancers, unlike other cancers that are caused by other non-modifiable factors. So this would be my third public health policy.
Yeah, and look, I think tobacco has been a great challenge, but we've seen huge successes around the world as well to bring it down, despite the efforts of industry to retain it. Andrea Parisi, it has been so interesting getting an insight into how a public health physician, how an epidemiologist operates, how you think, and so sharing the way you have has been really, really beneficial, and I hope it provides an encouragement for others to follow in your footsteps and allow the career as you started to take you step by step. Thanks very much.
Thank you very much for the opportunity to talk to you, Michael. Thank you.